Thank you very much. I'm told I'm starting the Beverly series, which is unusual for my primary presentations. So I'm just going to talk about developing a neurooncological service. And my thunder's kind of been taken away from having the group discussion that we did because the points are very, very similar. Neurooncology obviously being close to my heart. There are very many pathways in many training programs in the Western world where people can diversify, but most of the neurosurgeons who are within the Kenyan context have had to do a little bit of everything. But now we're reaching a critical point where the question is, do you diversify the individual or do you diversify the service so that one person does multiple things, or do you get one person to specialize in one thing? So what does it take once you're starting to think about that? There's the surgeon's perspective, the team's perspective, audit and protocol, research, finance, and training. And honestly, from a surgeon's perspective, we do think we're something special. I think our anesthesia colleagues will agree. Sometimes we see things from our world, this training that I want to do, this skill that I want to apply, and we collect instruments, we collect services and resources around us as individuals rather than the patient, who ideally should be the focus. So we spend a lot of our time learning the approach. And I think the joke was in the early part of neurosurgery, it was how big can you go? So, big skull-based approaches, big tumors, etc. And now is how much can I do through a very small opening? So we're all about minimally invasive. But once again, it's a little bit of a flex on our technical abilities to do things that most of society considered to be on a godlike perspective. And then this is the same where we're looking at, and then the tools. The tools are, I think that although I once went to, I was visiting a major center in the US, and I remember thinking that they had more microscopes than the whole of the United Kingdom in one center, on standby, not even in the OR. I think that the ability for us to accrue resources in a very specialist way can sometimes detract from what is the fundamentals of the service that we're trying to provide. But still, we do need some ability to look at what we can develop. So, of course, the first tool is the team. If we look at the distribution of microscopes, most of the microscopes in Kenya are around Nairobi, but we do have one in MTRH, we have one in Nyeri, we have one at the coast. So then the question is, should we invest in more microscopes or exoscopes? Once again, that is, should I drive a Ferrari or a Maybach or a Ford? And there are many reasons why you may go for one or the other. We're grateful that we have a neuro monitoring service that is embedded in the country, pretty much because of the work of one man, Patrick Gashema, who I really applaud. He has trained a lot of people, and so now you can find neuro monitoring in most centers if you ask for it. The challenge, though, is that it is an externally supplied service. So you have to call them and then they have to come in, rather than it is a part of the institution. And that has questions around audit work and protocol development. As I said, neuronavigation is only in 2 centers, and Aga Khan no, actually, it's in 3 centers. I stand corrected. There is Aga Khan and Nairobi Hospital, who are competing on which S version they have. And then you have, and Nairobi Hospital is winning. And then you have Kijabe, which has Brain Lab. But then for a long time, the Brain Lab was not being used because there was no neurosurgeon. So sometimes there can be a mismatch between the skills and the individuals. And then endoscopes are widely available, drill. The ultrasonic aspirator in the country is with the liver surgeons in Kenyatta. So none of the neurosurgeons have access to an ultrasonic aspirator. We now have access to radiosurgery, and we do have implants, various implants that you can utilize. I think the key one is, we talk about hydrocephalus, which is the most commonly used one, but we largely have the Shabra shunt, and that's what you call the poverty of choice in the developing world, where you can have the money but not access. So I'll jump the radiosurgery. So that's the surgeon. We're looking at how skilled am I, how much can I do, etc. But we also need to consider what we have when we're putting together the team. We're about 43 neurosurgeons. If we look at the spine orthopedics, they're about 40. So they do some vertebral body tumor work. I'm not so sure how many max facs we have. I think they're about 20. ENT is probably about 40. Plastics about 25. But when you come to other skills like neuroradiology, there are only 2 trained neuroradiologists in the country. And about 25 oncologists, and none of them is a neuro-oncologist. That's not counting the pediatric oncologists. I think they're less than 10. And only Kenyatta can do to give, because you need to give general anesthesia if you do radio-oncology work, it's only Kenyatta. So we have a system where we've developed a lot of equipment in different centers, but not really thought about how this service works. We haven't mapped out how the patient moves through the service. We have 2 neuropathologists, Aga Khan has one and Kenyatta has one, which means that centers like Tenwek, etc., can send it to Aga Khan. But the question is whether that is the best way we should have and whether we should be having a neuropathology. And we have 3 PETs. We have one in Aga Khan, one in KU, and there was one recently commissioned in Nairobi West, but it's not yet in active service. So, as we're saying, Kenya is moving very, very fast. It's getting loads of different things. I think one person that I met is in a football team, used to play in North Carolina. And so we have a situation where we have very many talented players, but we haven't yet developed the concept of a team. So we don't have the Steelers here, we don't have whatever team that you support. We're still working on that concept of it's not just about having superstars, but it's having a functional team. And then I think we have no coordinators, although Tenwek uses a social worker. So the other thing that's interesting about Kenya is majority of the oncology operations are done in the private, not the public sector. You ask me, how is that possible? Well, if you look at Nairobi, the public hospital is Kenyatta National Hospital, which has 10 neurosurgeons, and they have 1 theater, which means on any given day, they're operating somewhere else. So, and because the public service will always have to prioritize the collapsing patient, the deteriorating patients, the stable oncology patient is going to access their care in the private sector. So we need to have a conversation around that, even as we talk about UHC, in the sense that whatever design we come up with, it's not going to be like the UK, where most services are provided in the public sector. It's not going to be like the US. We happen to be a socialist country with a capitalist economy. So we have to design care pathways that are unique to our reality. A patient may be seen in a public hospital, get their surgery in a private hospital, go back to a public hospital for their radiotherapy and receive palliative care in a faith-based home. And there are many reasons for that. Most of us Kenyans are young, so we move to capital cities, we move to big centers to work. But when we get sick, we start to make that journey back to what we consider our ancestral home, because the probability of care and having access to carers is more likely in the rural environment. Are we together on that one? So that's a peculiarity of our setting. So the reason I mentioned that is that if any system that we design has to bear that in mind. Then when we come to audit and protocol, the ability to review your service and make sure that it's up to scratch. I will start by saying none of the protocols that are designed in the Western world are truly translatable to the Kenyan context. The first problem we have is that if you design, say, a protocol like the IANO protocol or you have the SNOW protocol, it has a lot of assumptions around access. It has a lot of assumptions about ability to pay. It has a lot of assumptions about standardization of care. Yeah? So it doesn't, when we talk about, for example, in trauma, the golden hour, for us it might be the golden week. So there are no protocols around what to do in the golden week that make you choose the right patient. And the same is true for our neuro-oncology work. So the first thing we have to do is a bit of research as to what are our agreed protocols. And then we can measure our service against that and see what is the most pragmatic, cost-effective, and effective treatment that we can provide in our setup. That being said, it's not a nihilistic thing. I have a lot of GBM patients that I have treated who 3-4 years down the road are not only working, but some of them have gone on to have more children. I never learned about that in my training. And a lot of information around Africa tends to be very nihilistic, like, oh, they're going to die and things like that. It's not true. We generally don't smoke. I'm not the best example. We're slimmer. And we generally have a very good social network of support. So if patients are given the right treatment and the families are on board with it, actually our patients do very well. Somebody in the family is going to bring them for their appointment, but the family must understand the implications for not doing their treatment. Then we still have a lot of work to do around safety protocols, and that's one for clinical governance issues. Because we're providing care almost like in a, sorry to use that example, but in an Uber service kind of way, it makes it hard to map up what is the safest way for the patient to transition and all the factors that can go wrong if the backup plans are not there. So that's another conversation that we need to have. When you look at accessibility, care for neurosurgery now is more accessible than ever, but we still have challenges in our belief systems because we've grown up with an understanding that neurosurgery means that it's a fatal condition, and so patients present late, they may go AWOL, they may go shopping for opinions. I think we've covered ad nauseum the issues that we have with funding, and that we're transitioning from one healthcare system in funding to another one, and we're not sure whether specialist skills, and especially long-term skills, will be catered for. I think one of the challenges we have is, so I did some research on the colonial history of Kenya and its impact on our training programs. And one of the challenges is that the fundamentals in the training focus around getting your worker back to the farm. Yeah? And so there was a lot more focus on trauma and infections than there are in consistent care through the episode. So when you look at oncology care, it's not an episodic kind of treatment. It's the ability to transition the patient from presentation to throughout the treatment plan. And because that isn't fundamentally within our health service, which focuses more on episodic management, we need to figure out whether the new system will allow for better progression of patients through their care pathways. Then the geographical distribution, most of our care is in urban areas, flexibility to access. But then the weird thing is Kenya doesn't exactly have a waiting list. Doesn't have a waiting list in the sense that if you know your surgeon and he has a private clinic, you could be operated tonight. But if you go to the public sector and you don't have the money and you have to wait for the public thing, then you are in a waiting list. So it's one of those weird things where we do have a waiting list and we don't have a waiting list all at the same time. So it means that we need to think around how oncology patients transition through care. Some people are laughing because they know what I mean. And largely, Kenya provides consultant-delivered services in oncology. So that's also another unusual thing compared to the American and the British system, where a lot of the work may be done by the residents. Most of the work is done by the consultants. So there's an opportunity there for fantastic outcomes because people tend to develop a relationship with an individual rather than a service. But the weakness of that is when that individual is not competent or that individual goes away, the patient may drop off care. I won't cover that. And then we have a challenge of catastrophic health spending, particularly in oncology. So then when it comes to research and training, most of the papers actually have been done by Fraser that go beyond case reports. So Fraser, we're going to miss you. So we looked here at the neuro-oncology capacity, our ability to access oncology care, our ability to access radiotherapy and chemotherapy. And honestly, it is one of the highest in the region. We have access to radiotherapy, chemotherapy, and pathology more than half the time. But the question is whether we are consistently auditing those to make sure that we can see the trends, the patterns, and we can improve our practice. I talked about the tumor registry when I was discussed, and also we're now forming MDTs. So there are now 3 MDTs. There's one in MTRH, there's one in Tenwake. No, that's more than that. There's one in Kenyatta, Nairobi Hospital, and Aga Khan. So the ability of team working is developing. What we don't have is, we don't compare those MDTs to see, can we do it better? So maybe Tenwake is brilliant at managing craniopharyngiomas. Aga Khan will never know about it. Aga Khan may be better at low-grade gliomas. Kenyatta will not know about it. So these are some of the challenges when we work in silos. So I said all that because I was coming back to the peace resistance, which is now that we want to form a brain tumor program, now that we want to be comprehensive, where do we stand? And the brain tumor program is not focused on the surgeon or the anesthetist, it's focused on the patient. That the patient gets a personalized, comprehensive, cutting-edge, multidisciplinary kind of care, and is inclusive and appropriate and does not neglect the support of the carers. So when we wrote these papers, we compared Asia and we compared Africa, and I'll come to the Kenyan results. And what we looked at were the tenets of surgery, oncology, pathology, research, training, and finances. And then we scored them. We had a matrix that gave points for each of those. And if you were a level 5, you scored particularly highly on access to all of those aspects. So that's the feasibility of brain tumor programs across Africa. And Kenya is in a light blue turquoise, depending on your color preference, which means we're ticking a lot of the boxes. We're not 100% there, but we're better than we think. We just need to put that into a more organized matrix so that our trainees can have very good grounded neuro-oncology cares and our patients can have even better care. So there are gaps. And how do we address them? I think I'm wary of time. Let me look at the opportunities. We've improved our surgical capacity, but we're still in silos. We need to improve our MDTs, and we need to work on the training of the rest of the team. So we need to get neuro-oncology nurses, we need to get neurocritical care. We need to form a registry. Now, the National Cancer Institute last year announced that they're starting to develop registries, and they're offering the same to the neurosurgical community. So what we need to do is to be willing to volunteer our information. Remember what I said, most of the neuro-oncology is happening in private practice. So we need to find a modality that allows for data sharing, so that if Tom comes to see me and then tomorrow sees Khalif can look at the system and say, I see what Beverly was thinking. I agree or disagree, or I need to have an alternative opinion. Maybe I need to loop in Beverly and we have an MDT with X to see what's the best outcome. And then if my patients, I do surgery for them, I think I'm a wonderful surgeon, but Ben gets to see them. Ben can write down about the complications, and I can be better informed at the next meeting. I think there's a formula for that that's already been applied when I was in the UK for acoustic neuromas. All the surgeons who did acoustic neuromas submitted their data, and then you could get an overview from a national perspective, and you can learn quite a lot, and this is how we'll leapfrog in understanding how to develop our systems better. I'll skip the other ones because we discussed them. So in summary, I think that there's a lot that we're doing well in neuro-oncology, and there's a lot that we can do better. There's a lot of things around organization, rather than thinking of ourselves as individuals. Kenya is a country of individual sports. We run marathons, we do javelin, we don't do football very well. We're okay with rugby, provided there's beer. So we have certain strengths. But now we need to think like the way the Americans think around their sports, or how the British think about their cycling, or the French think about, what do the French think about? Their food? No, I don't know. But we need to think more about how do you improve the system rather than the individual to get the best for the patient. Thank you.
Any questions? Any questions, anyone? All right, thank you so much.
Oh, there's a comment from Lee.
Oh, do we have a mic?
Thanks, Beverly, for the wonderful talk. It's a quick question about how our patients respond when they have brain tumors, and there was an issue earlier about shopping and also some cultural kind of perceptions and maybe roadblocks to accessing care, where even when the care is accessible, we have a lot of hesitation from our patients. I have those who come and say, when you give them dexamethasone, they feel better. They say, I've gone for prayers, I'm fine, and they vanish. I don't know what you think about how we can get the word out, perhaps that a different perspective might end up in better outcomes when these guys come early and we catch the issues early.
I think the first thing is we need to organize ourselves better. I think that, as you know, increasingly, people who come from Kisumu, we just tell them to come and see you rather than travel to Nairobi. People who are near Tenwek, we send them to Tenwek. We need to be each other's advocates. Rather than thinking, I am better than you, we're on the same team. The ball is, what we need to do is get that ball in the goal. And so we need to start first by putting our preferences aside, for lack of a better word, our egos aside, and start to become each other's advocates and tell everybody where we are based so the patients can access that. Because I find that a lot of patients take our word when we say, oh, so Dr. So-and-so, he's brilliant. They'll stop window shopping. I've had patients come to me and then go back to the first person they saw because I said, I don't understand why you came all this way when you're in very capable hands. Yeah. So I think we need to do that more first to reduce that. The second thing is we need to do a little bit more advocacy. We do in the way that is suitable to our culture. Here there are surgeons from different communities, different backgrounds, different school backgrounds, etc. We need to go back to our schools, we need to go back to our villages, we need to go on our vernacular stations and talk about neurosurgery. There is something that hits differently when somebody says it in Swahili or the Luo or Kalenjin. And that really helps the decision makers, because often the decision makers are not in clinic with us. You're seeing a young person, but that young person needs to go back, speak to the dad. The dad has no idea that Leo Gudha is someone, and when he looks at the picture, he's like, this is a young man. So it would make a lot of sense if Mr. Olocho Lunya went on, which one is it? The Luo FM? Which one? Ramogi. And talked about how wonderful things are happening and Lee is involved. I promise you, next time they'll come to you and they won't go anywhere. Yeah. Same with the Kalenjin community or the Kikuyu community or whichever one. We need to start with our local understanding. Our Asian community, our Arab community. We have all these communities that make the fabric of Kenya. Then we need to form. We now have two groups, IANS and NSK. We don't do much advocacy work that compared to the capacity that we have. So outside of camps, we need to be constantly putting out information, maybe run a website, so that if you come to clinic and I say something, then you can say, oh, look at braintumorkenya.org, yeah, or look at whatever. When they go there and it's the same information, they'll be like, what's the point of going to see 5 other people? They're going to tell me the same thing because it's validated as a group. So those are some of the things we can do to help. We are responsible for where we got. We got here because of some of the choices we've made. Yeah?